we treated some disorders with GIT, but we couldn't complete. So today, we continue with the remaining disorders. So now we begin with antidiarrheal agents. That means these are drugs to target the frequency of stool, okay, that one passes out. So diarrhea may be acute or chronic and can range in severity from mild to life-threatening ones. And there are so many causes, including infectious agents due to toxins, anxiety, and drugs. Diarrhea involves both an increase in the motility of GIT and secretions. There is also decreased fluid absorption, leading to electrolyte and water loss. So here in this case, when one gets diarrhea, they lose water as a result of this absorption of electrolytes, okay, in the stomach, and therefore wherever these electrolytes are, water follows. And due to the increase in motility of the GIT, the gut, and secretions, then diarrhea sets in. So here there are three major ways one can tackle diarrhea. So one way includes maintaining the fluid and electrolyte balance. Remember, you are losing electrolytes as well as fluids when you have diarrhea. So one way is to replace or replenish the fluid and the electrolytes that have been lost. Okay, so one way is by replenishing them, as well as the second way is the use of anti-infective agents. So there are so many drugs designed to tackle whatever and also we have the third approach, which is the use of non-antimicrobial antidiarrheal agents. So these are drugs, they don't have any antimicrobial activity, okay? But that approach is there. So we'll talk about it in details. So the first one talks about maintenance of the fluid and electrolytes balance. You remember that in diarrhea is the passage of these watery stool, and here you are losing fluids, and not only fluid, also you are losing electrolytes as well. So here, the first thing you have to do is to maintain that fluid and the electrolyte balance. So oral rehydration should be the first priority, and many patients require no other treatment measure apart from rehydration. So here it comes in the form of preparing sodium chloride and glucose, and this has been found to be effective. It is also ready to use, and also it is dissolved in water and are mostly available as ORS. In the ileum, there is a co-transporter of sodium and glucose, and the presence of glucose aids in sodium absorption. The absorption of sodium will also enhance water absorption, because wherever salt or sodium goes, water follows. So as soon as sodium is absorbed, water is also absorbed. And you all know that most drugs that we take in gets absorbed, okay, depending on the location. So if it is a basic drug, it is mostly absorbed in the small intestines, particularly in the distal ileum, okay? And whilst for acidic drugs, it can be absorbed in the stomach, particularly in the proximal duodenum. This is just pharmacology 1, okay? We will talk about it. So it's either for acidic drugs, and like I said, it's mostly in the stomach and the proximal duodenum, whilst basic drugs is mostly in the small intestines or the distal ileum. Amino acids have a similar effect like the glucose. So remember I said the glucose allows sodium absorption. So if we don't have glucose, amino acid can be replaced for that function. Now we move on to the use of anti-infective agents. So here, not usually necessary, since most often the microorganisms are viral. Those of bacterial origin generally could resolve without antibacterial drug therapy. However, serious diarrheal infections due to infections may require antimicrobial agents. So we have Campylobacter species, the commonest bacterial organism. And here you can use drugs like erythromycin or ciprofloxacin. Okay, so ciprofloxacin is mostly a broad antimicrobial agent. Now let's look at the non-antimicrobial antidiarrheal agents. So these are agents used as adjuncts to provide symptom relief. So first, we spoke about maintenance of body of the fluids, electrolytes, that approach. Second is the use of anti-diarrheal agents. And the third approach is the use of non-antimicrobial antidiarrheal agents. So now we're on the non-antimicrobial antidiarrheal agents. And here, drugs which are often used include opiates, antimuscarinics, and adsorbents. Okay, and these drugs have the tendency to decrease gastrointestinal motility. So let's start with opiates or opioids. Here, they are the most efficacious antidiarrheal drugs. They exert a non-specific effect that can control diarrhea. They also induce a sustained segmental contraction of intestinal smooth muscle. This prevents the rhythmic waves of contraction and relaxation. So what this does is that as it contracts the intestinal smooth muscle, there is no movement. So it helps prevent peristalsis at the end of the day. Now, opiates effects are mediated by opioid receptors present in smooth muscle. So remember, there are receptors for opiates or opioid, okay? And there are various kinds. We've got kappa, we've got mu receptors, but together we just classify them as opioid receptors just to play safe. We'll talk about it into details in the following weeks to come. Opioids in pain management. Now, all the potent opioid receptor agonists are effective antidiarrheal agents. So we have the main opioids used in diarrhea treatment being loperamide and diphenozylate. Okay, loperamide and diphenozylate. They are all opioid drugs. Now, these agents selectively act and activate intestinal opioid receptors, and they play little role on the CNS. So we have loperamide, also called Imodium, and this has the tendency to reduce the frequency of passage of feces. After oral administration and absorption, it undergoes significant enterohepatic enterohepatic cycling. I hope you all know about the enterohepatic cycling. This is pharmacology 1, where drugs, instead of it moving on from the liver through the hepatic portal vein, okay, and moving on into for distribution to other tissues, this drug doesn't move on. It goes back to the bowel, and then it is secreted into the small intestines again, and then reabsorbed. So it's like a cycle. When you get to pharmacology 1, or you are taught in pharmacology 1, this will be explained in detail. You can also Google to find out what enterohepatic cycling means. But here, all I'm trying to say is that the drugs does not go into systemic circulation, but they are recycled, okay, in the liver. And so from the liver into the small intestines, it will be absorbed again and goes back to the liver, and then is being released again through the bowel secretions back into the small intestine. So it's just a cycling. In that case, it prolongs the half-life of the drug. So that's pharmacology 1. So here, mostly used in travelers' diarrhea. You know, there are some people who always get diarrhea, and therefore opiates is the required drug for them. Now let's look at the diphenolate. It also has very little effect on the CNS. However, large doses produce typical opioid effects. So most often preparation contain atropine or Lomotil. Now let's look at the antimuscarinics. These agents are seldom employed as primary therapy for diarrhea. Their use often leads to several adverse effects, such as dry mouth, urine retention, and many more. Most often, small doses of atropine is combined with diphenolate. Okay, so example is the Lomotil. Now let's look at adsorbents. Now these agents act locally within the gut by absorbing water and toxins or reducing secretions. So we have Kaolin-pectin and polycarbophyl as examples of drugs that absorb water and toxins. Now, polycarbophyl appears to be better absorbent than kaolin-pectin. Okay, so there have been a lot of research done on kaolin. Okay, mostly is from this to absorb. Now let's look at the antispasmodic agents, which can be used in the treatment of spasms in the GIT. And I remember yesterday, a gentleman asked me of hyoscine or buscopan. So here is where we talk into details about antispasmodic agents. So they are also called spasmolytics. Always remember, lytics means breakdown. So breakdown of spasm. Antispasmodics are drugs that relax the smooth muscle of the gut. These agents work primarily through anticholinergic activity. They are used to relieve cramps or spasms of the stomach or intestines. So cholinergic activity and anticholinergic activity would be our next focus after respiratory pharmacology. So don't worry, we'll deal with that. Okay. Now, with the antispasmodics, we have two main groups of the drugs. So we have drugs affecting autonomic innervations, which are anticholinergics, and we have drugs directly affecting smooth muscle function, and they are known as relaxants. So let's start with the anticholinergics. Now, for them, they decrease spasm by inhibiting parasympathetic activity. We all know the parasympathetic activity. It involves rest, eat, and digest. Mm. While the sympathetic activity always deals with flight, and fight. Mm. But here, anticholinergics always act to inhibit parasympathetic activity. So indirectly, it is enhancing sympathetic activity. Now, they antagonize mostly muscarinic receptors in the GIT. Please mind you, with the muscarinic receptor, it's mostly parasympathetic arm, okay? So they block the parasympathetic arm, like what I've written. It inhibits parasympathetic activity. So they block the parasympathetic arm via the muscarinic receptors. Hmm? In the GIT. We'll talk about this into details when we start cholinergic pharmacology. Okay, so agents available include hyoscine, butabromide, so buscopan. We have propantheline and dicycloserine. On the other hand, we also have muscle relaxants, and different mechanisms of action are involved, and these include inhibition of calcium channels. Remember, wherever calcium is, normally contraction is involved. So when you inhibit calcium, then of course you are not going to have contraction. So relaxation of this muscle can be inhibited by inhibiting calcium channels and activation of potassium channels and stimulation of nitric oxide synthesis. So nitric oxide synthesis always allow relaxation of vessels, especially, but here in GIT, it relaxes the muscle, okay? And whenever a muscle is relaxed, normally nitric oxide causes vasodilation because it's relaxed, so the vessels are able to, expand or widen. So examples of drugs here include mebeverine, drotaverine, and alverine. Okay, so these are muscle relaxants. Please try to keep these drugs. I told you I'm going to ask questions on drugs and not pathology. So make sure you keep or memorize these names: mebeverine, drotaverine, and alverine. Now let's look at the anti-emetic agents. I know many of you, if you've come to realize during VAS day, a lot of ladies vomit. But I'm not saying it's due to that activity that they did. But here in this case, even when you give them anti-emetic, it won't work because the causative of that vomiting effect is not due to any other thing regarding it involves the vomiting center, but they did something dangerous, okay? Anyway, that's just by the way. So anti-emetic agents, these are drugs, okay, given to prevent vomiting or emesis. Now, vomiting, how is it initiated? Okay, so it is initiated by a nucleus of cells located in the medulla, okay, in the brain. Now, this nucleus is called the vomiting center. The center coordinates a complex series of events that causes reverse peristalsis. We all know that peristalsis is just the movement of maybe a substance or food from the mouth to the stomach. But here is the case that there is a reverse peristalsis or a backflow. So whatever contents inside the stomach is now moving back through the mouth, and then you spit or you vomit them out. Now, this reverse intestinal contraction is associated with nausea, which may occur in the absence of vomiting. You remember I said nausea always precedes vomiting. Now, the vomiting center may be activated by efferent fibers arising from the gut. And we have the chemoreceptor trigger zone or the cortex. Now, notice that this chemoreceptor trigger zone, okay, is in your stomach as well as in your brain. Mm? That's why when you take in drug, like a bitter drug, okay, you can easily vomit it because upon its encounter with the chemoreceptor trigger zone, it can trigger the vomiting center, and therefore you end up vomiting. So here we have the chemoreceptor trigger zone responding to blood-borne substances such as cancer drugs. The chemoreceptor trigger zone is activated when serotonin, dopamine, histamine, or muscarinic receptors are stimulated. Okay, most antiemetics act by blocking dopamine, serotonin, muscarinic, or histamine receptors. Okay, so mind you, dopamine when it is reduce dopamine in your system, then therefore you are trying to what? Block or prevent vomiting. Okay. And you blocking dopamine indicates that you are reducing dopamine. And in that case, uh, it can lead to Parkinson's disease. Okay. Parkinson's disease comes in when dopamine levels are reduced. So normally, if someone is having Parkinson's disease and he's vomiting, normally we take caution when prescribing anti-dopaminic or and drugs targeting the dopamine receptor. Okay, so it means that you can give all drugs to block these serotonin, histamine, or muscarinic receptors, leaving dopamine. Because when you give an anti-dopamine or a dopamine antagonist, then you are rather going to cause the Parkinson's disease to be worse. Because Parkinson's disease is associated to low levels of dopamine. Now, most antiemetic acts by blocking dopamine, serotonin, muscarinic, or histamine receptors. So this is just a diagram showing how one vomits. So we have the vomiting center, which is in the brain. And here, it can be triggered by these two ways. So we have the chemoreceptor trigger zone. And the chemoreceptor trigger zone is as a result of uh, 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 these receptors being activated. So we have the histamine, dopamine, 5-HT3, serotonin, the muscarinic, okay? And for these receptors, they are activated. Once they are activated by drugs like chemotherapy, it can cause the chemoreceptor trigger zone to induce vomiting. Mind you, the chemoreceptor trigger zone is also located close to the brain, but it is outside, okay, the barrier, the blood-brain barrier. Please mind you, there are barriers in our systemic circulation. So we have let's talk about the physical one, which is the skin. Okay, the skin acting as the physical barrier. We have the blood-brain barrier, which is located in our head, and we have the testicular blood barriers, the blood testicular barriers, okay, and we have the placenta blood barriers, okay. So with the chemoreceptor trigger zone, these receptors can trigger the vomiting center. We can trigger the chemo receptor trigger zone, which will also trigger vomiting in humans. Okay. Now, and like I said the chemoreceptor trigger zone, although it's located in the brain, it is behind the blood-brain barrier. So in case we have the blood-brain barrier here, okay, drugs which you take inside and is inside systemic circulation can encounter this and then trigger vomiting center. Okay, but these drugs can't cross the blood-brain barrier to have an effect on the vomiting center. Had it not been, if the chemoreceptor trigger zone should be in front of the blood-brain barrier, then these drugs cannot trigger this chemoreceptor trigger zone. But because it is, and the drug meets it before it gets to the blood-brain barrier, that's why it's able to trigger the vomiting center. Also, so this is one way. Now, the other way which can also induce vomiting is by the histamine and the muscarinic receptors in our inner ear. So especially when we like motion sickness, okay? Motion sickness causes you know signals to be released, and there are receptors H1 and muscarinic receptors playing a role, and when they become triggered or stimulated, they can also trigger vomiting, the vomiting center, and therefore vomiting. And here serotonin, which is a mediator of inflammation, can be in the blood vessels, get into the chemoreceptor trigger zone and stimulate vomiting. Also, drugs which we take, okay, can get stimulated by these receptors and also goes in there and trigger the chemoreceptor trigger zone and then induce vomiting. So this explains the mechanism of vomiting. So we have one mechanism, two here, three here, and four. When you take in drug, especially chemotherapy drugs, okay, or beta drugs like those days we have the chloroquine, the beta one, okay. Now for the serotonin receptor antagonists, remember I said some are inflammation mediators, okay. So we have a drug like ondansetron. Please, the line will go off and after 10 minutes. So I'll give you the link so that we finish with this section, okay? So ondansetron was the first selective serotonin receptor antagonist, and it was developed to treat cancer chemotherapy induced vomiting. It was found to reduce the number of episodes of emesis, which is vomiting. We have Granisetron, which is currently a newer agent having almost similar clinical efficacy as the ondansetron. Now, the two drugs have a structure similar to serotonin. That's why they are able to bind and competitively block the serotonin receptors on visceral afferent nerves in the GIT and the chemoreceptor trigger zone. This reduces both peripheral and central stimulation of the vomiting center. Now let's look at the pharmacokinetics of the drug. Remember, in pharmacology, is the pharmacokinetics and the pharmacodynamics that is very important. That plays a major role in pharmacology. Aside the toxicity or the toxicological role. So these drugs can be administered orally or intravenously. They are extensively metabolized by CYP enzymes. Metabolites are primarily eliminated in urine. Here, the half-life of ondansetron is 6 hours, whilst granisetron is 4 hours. Now, how do we use them clinically? Both drugs are used for cancer chemotherapy induced emesis. So to prevent one from vomiting the drug that you've taken, you give the ondansetron, okay? And the ondansetron is also approved for treatment of post-operative emesis. Now, neither drug is indicated for the treatment of less severe nausea and vomiting, partly because the two cost more than other antiemetics. Oral ondansetron is usually administered prior to chemotherapy. It is continued 3 to 5 days after chemotherapy course is complete. A combination of the ondansetron and dexamethasone controls emesis in persons who have failed to respond to ondansetron only. You remember dexamethasone is a glucocorticoid, okay, and it helps prevent inflammation. So ondansetron, now let's look at the adverse effects. Ondansetron and Granisetron are well tolerated and usually produce few side effects. The most common side effects include headaches, constipation, and diarrhea. Less common ones include hypertension and elevated hepatic enzyme activity. Now let's look at the dopamine. You remember I spoke about dopamine. Low levels of dopamine can cause Parkinson's disease. Okay, so it's not advisable to give an antagonist, okay, of dopamine because to a Parkinson patient. So we have one of the greatest boxers dying from Parkinson's disease. I hope you know him. He's named Muhammad Ali. If you follow boxing, you know about him. So we have the D2 receptor antagonists, and these include the prochlorperazine. Okay, we have the domperidone and metoclopramide. Now, all D2 receptor antagonists appear to act primarily on the chemoreceptor trigger zone to inhibit stimulation of the vomiting center. They also have the tendency to inhibit afferent impulses. Now, with the prochlorperazine is a phenothiazine, okay? That means, and it has antipsychotic and antihistaminic effects. It is also widely used in the management of nausea and vomiting. In patients with cancer chemotherapy-induced emesis, the efficacy of prochlorperazine appears less than ondansetron. So we have the metoclopramide, which inhibits vomiting by blocking not only dopamine, but also serotonin receptors in gut and CNS. It has prokinetic activity, which does not only add to its anti-emetic activity, but why is it used for conditions such as GERD? So we'll talk about it later. It has been found to be less effective than ondansetron in preventing cancer chemotherapy-induced nausea and vomiting. However, phenothiazine compounds and metoclopramide remain viable options for treating nausea and vomiting of other causes. Higher doses of phenothiazines are more effective than lower doses. At these higher doses, there is a high tendency for hypotension and extrapyramidal side effects. Let's look at the other approach, which is an antimicrobial agent. So we have the cannabinoids, and there have been great evidence, enough evidence, which suggests that cannabinoids are good antiemetics. So we have some synthetic derivative being nabilone and dronabinol. They decrease vomiting caused by agents that stimulate the CTZ. The drug probably acts on the vomiting center in the medulla. Now, the exact site and the mechanism of action are still uncertain, are still not known. So we have dronabinol, which is approved for treatment of cancer chemotherapy induced in meses. The drugs have about the same efficacy as the phenothiazines. It is less effective than ondansetron or metoclopramide. Common unwanted effects include drowsiness and dry mouth. Mood changes and postural hypotension are also fairly frequent. Some patients experience hallucinations and psychotic reactions. In, I think, 1 minute time, it will end. Oh, so we have 3 more slides. Okay, let me see if I can do it within 1 minute time so that we end the section for today. So we have the histamine receptor antagonists. So there are so many antihistamine, which includes diamine hydranate and meclizine, and they are used in the management of motion sickness. So we have promethazine, which has significant antimuscarinic activity and is used to prevent nausea and vomiting. Now we have antimuscarinic agents, which are to block the activity or the parasympathetic arm. So we have scopolamine, which is an antimuscarinic primarily used for the prevention of motion sickness. And you know how motion sicknesses come about, okay? So a person traveling in cars or planes for the first time in boats can normally experience motion sickness. It has been used by astronauts in space. So we have scopolamine available as skin patch, which release slowly through the skin over 72 hours. Now let's look at steroids. So we have high-dose glucocorticoids. Example is dexamethasone and methylprednisolone, and they can also have antiemetic action. The mechanism is not clear, but may involve the ability to inhibit prostaglandin synthesis. You know, I told you that dexamethasone affects inflammation, and prostaglandin synthesis plays a role in both mucus production and inflammation.